The most common, I suppose, clinical use of cough reflex testing is to evaluate the sensory integrity of the upper airway. We know that patients with blunted upper airway sensation are at risk of silent aspiration, and I think this is a really valuable tool for identifying that.
We are really happy to have had Dr. Emma Wallace as our guest on Dysphagia Matters. She is a postdoc and lecturer at the University of Sydney in Australia. Together with her co-authors, Professor Maggie Lee Huckabee and Dr. Phoebe McRae from New Zealand, she wrote a spotlight article on cough reflex testing in clinical dysphagia practice. But what is coughing? What is the cough reflex all about? And how can we test it in clinical practice? We asked Emma this and a lot more. Enjoy listening.
Hi, Emma. Thanks so much for joining us on the podcast to talk about cough reflex testing and your clinical tutorial paper that you have just published. Congratulations on such great work.
Yeah, thank you so much. It's really nice to be on and speaking about the paper.
So first of all, would you mind sharing with us how you got to work in the field of cough and cough reflex testing and also doing research on it?
Yes, so that's been a very long and winding path. So I did my undergrad or bachelor's degree in Trinity College in Dublin. And I always had an interest in dysphagia when I was doing my undergrad degree, and really had an interest when I moved into clinical practice as well. Dysphagia was always an area that I loved. I loved physiology. I loved learning about anatomy and physiology with swallowing. So it was an area that I always had an interest in. I decided shortly after I graduated to take the plunge and move to New Zealand, the other side of the world, to do what originally was a master's degree. And my master's research program was on cough testing. And it was actually on looking at cough strength testing in response to the cough reflex test. So that's the project I originally started on. And my mentor over there, Dr. Phoebe McRae, ended up getting this large research grant while I was there. And she invited me to stay and do a PhD under the supervision of herself and Professor Maggie Lee Huckabee. So I suppose the rest was history after that. My PhD was on kind of assessment and rehabilitation of the sensory motor cough response. So it was really focusing on sensory rehabilitation of cough. And since then, I've continued to do some research in the area, and I'm now based at the University of Sydney as an academic. So I do research and teaching.
Perfect. So maybe we start with talking about coughing in general. So what is coughing and how does it work on a neurological and physiological level?
Yes, so this is an extremely complex question. I'm definitely not an expert on the neurophysiology of cough and the precise neurophysics. And I actually draw a lot on Stuart Mazzoni's work in Melbourne, who's a great cough neurophysiologist to learn about this. I find the topic really fascinating. But from my own understanding, the neural control and neurophysiology of coughing will largely depend on what type of cough we're talking about. So a true reflexive cough is theoretically controlled in the brainstem. The cough reflex test has both a sensory and motor arm, and innervation to the larynx is provided by cranial nerve 10, or the vagus nerve. I think in the case of an aspiration event, a little branch of the vagus nerve, the recurrent laryngeal nerve, provides sensation below the level of the vocal cords. And in a healthy person, this tends to sense the aspiration and a motor cough response is produced. And this type of cough response is also elicited when there's kind of sputum or phlegm in the trachea. For example, when we're sick or have an upper respiratory tract infection, this is the same kind of neurophysiology. In the case of laryngeal penetration, the superior laryngeal nerve, so that small branch of the vagus nerve, provides sensation above the level of the vocal folds. And this will sense kind of misdirection of food, fluid, or saliva and produce a protective cough and other airway clearance mechanisms in response. So in reality, when we aspirate, it's likely that both the recurrent and superior laryngeal nerve are sensing this and controlling the brain to kind of elicit that airway protective and airway clearance mechanisms. And I think this is quite interesting. We historically thought of coughing as this reflexive response. However, we now know that there's a huge amount of cortical input and cortical control of coughing. For example, healthy people can often suppress or down-regulate a cough response if they're in like a fancy restaurant or in a lecture theatre. So in most cases, I think coughing isn't a truly reflexive behaviour. So we've kind of evolved our thinking in that respect.
Yeah, that's really interesting. And it's a good point. We always talk about it as a reflex, but like you say, we actually can control it. And you've mentioned a few already. So there are different types of coughing. Could you maybe summarize these again?
Yes. So I think this is where it can get kind of tricky because different researchers and different research groups often use different terms to refer to different cough types. So reading the literature, it can actually get a little bit complex. And it can often depend on what field the cough researcher is based. If they're looking, if they're evaluating cough from a chronic cough perspective or a respiratory medicine perspective or a dysphagia perspective. So these kind of terms can be used interchangeably or different depending on the kind of perspective the researcher takes. But theoretically speaking, we can have a reflexive cough. And this type of cough is produced with absolutely no cortical input in theory. It's been described in the literature kind of way back in the 40s and 50s in decerebrate animals where they would remove the cerebral cortex and then stimulate certain parts of the larynx to kind of produce this type of truly reflexive cough. We can also kind of on the other end of the spectrum have a volitional cough, and this is like a cough that's produced on command. So if I said to you now, cough, and this type of cough can be elicited in response to absolutely no sensory input and is very much cortically controlled and cortically mediated. And it's often the cough that we actually assess in our cranial nerve exam when we ask patients, can they cough? And then it kind of gets a little bit challenging because, we can have a cough response produced to very kind of low levels of sensory input in that this type of cough, if we have a bit of a tickle in our throat, and this type of cough could be suppressed or it could be elicited depending on what the individual decides. And there's high degrees of cortical input when we have a very low sensory stimulus. But this cough type is still preceded by some sort of sensory irritation or sensory stimulus to the larynx. Then I'm kind of moving the other end, I suppose, towards more reflexive type cough. We can also have a cough produced in response to a very high level of sensory input or a high sensory irritation or stimulus, which cannot be suppressed or is more difficult to suppress. And this type of cough is still subject to cortical input, but it's probably more reflexive than the latter cough I just described. So when I'm talking about these type of coughs, I tend to use the term sensory motor cough response rather than a reflexive cough. Just to kind of capture the fact that they are preceded by a sensory stimulus, but depending on the kind of intensity of that sensory stimulus, we can have a more volitional or cortically controlled cough or a more kind of reflexive or a cough that lies more on the reflexive side of the continuum. So yes, and I think the level of volitional or reflexive control can largely depend on, if there's a sensory stimulus, whether that's a big or little sensory stimulus, I suppose the sensory integrity of the individual's larynx, among kind of many other things. So there's kind of this continuum that I like to see reflexive volitional coughing lying on.
And which type of coughing occurs then when we penetrate or aspirate food or liquids?
Yes, a very good question. And I think it's really interesting because we actually have very little knowledge on kind of the precise physiology or neurophysiology of coughing in response to aspiration. And this is probably due to the ethical challenges of collecting this type of data. Although I will say, kind of as speech language pathologists, we're really well positioned to kind of collect this type of data or collect this type of information on coughing to aspiration during video fluoroscopy or during our instrumental swallowing assessment. So really there's little information in the literature, but I think we as speech pathologists can definitely contribute in that area. But when material enters the airway, it's likely that a laryngeal expiration reflex, or LER, you might see in the literature, is elicited. And this type of cough involves this rapid closing of the vocal folds and this expiration reflex in order to kind of expel material from the upper airway or expel it from the laryngeal vestibule. So interestingly, there's no inhalation preceding this type of LER response or laryngeal expiration reflex. But it's likely that this laryngeal expiration reflex is then followed by bouts of reflexive and volitional coughing once the initial material has been expelled. And I think we all kind of have experience of that. When something's gone down the wrong way, we have this initial response and then we seem to kind of cough multiple times to clear what we feel is left there. But I think it's also really important to recognize that coughing isn't the only response to laryngeal penetration or aspiration. And Michelle Trichet and colleagues published an amazing paper that I refer back to continuously, highlighting this continuum of airway protective and airway clearance mechanisms that we elicit to defend the airway. And these can include things like throat clearing, expiration reflexes, coughing. So our response to laryngeal penetration and aspiration likely comprises kind of many of these behaviors. So it's quite an interesting and integrated response.
Thank you, that's great. Now that we have an overview of the physiological background, let's move on to cough reflex testing. What is a cough reflex test, and in which way can it be used in dysphagia management?
Yes. So really interestingly, cough reflex testing has been actually around in the field of respiratory medicine for 60 to 70 years. And it was actually historically used or developed to evaluate the effects of antitussive or cough medications, so like cough bottles or cough syrups that we have on our shelves. And it's only really been adapted to our field, the field of dysphagia, probably in the last 10 years. So the most common, I suppose, clinical use of cough reflex testing is to evaluate the sensory integrity of the upper airway. So when I say upper airway, I'm kind of meaning the larynx and the trachea. And, the way in which cough reflex testing works, for those who aren't familiar, is that individuals inhale a concentration of citric acid or another tussogenic agent. So capsaicin is also used by some clinicians and researchers. And they inhale that aerosol at concentrations that we know elicits a cough response in healthy individuals. So for citric acid, it's 0.6 moles of citric acid is what I use, because we know that elicits a cough response in healthy individuals. And we observe for the individual's response to this inhalation. And when we see a cough response, it suggests that the individual or the patient has intact upper airway sensation. While if we see no cough response, it suggests that the upper airway sensation may be blunted. And a number of studies have validated the use of citric acid cough reflex testing to identify patients who may be at risk of silent aspiration due to blunted upper airway sensation. And these studies I've kind of summarized in the Spotlight article that's recently published in Advances in Communication and Swallowing. So I think, cough reflex testing has kind of emerged in dysphagia clinical practice for this use as a screening tool to identify patients who may be at risk of silent aspiration.
Okay, I think you kind of already answered my second question, which was what can a cough reflex test do and what can it not do as a screening tool? So maybe you can explain also the possibilities and where also the boundaries are of this test.
Yeah, absolutely. And I think, like many other screening tools that we have in our practice, the cough reflex test is definitely not perfect. The test provides us with, some indication about a patient's upper airway sensation to an airway irritant. So, it essentially evaluates the integrity of cranial nerve 10, cranial nerve sensory, which is quite challenging, I think, to do otherwise. We've no other methods of evaluating cranial nerve 10 sensation in our clinical practice unless we use something like FEAST or, with endoscopy. So it's a very valuable way of testing that part of our cranial nerve exam. And, the way, I suppose, the test works in such, we're essentially using citric acid to mimic an aspiration of food fluid and saliva and observing how the patient might respond in response to such an event. We know that patients with blunted upper airway sensation are at risk of silent aspiration. And I think this is a really, it's a really valuable tool for identifying those patients who may be presenting at risk of silent aspiration. But one thing I will say in terms of the boundaries of the test, it's important as clinicians that we recognize that not all patients with blunted upper airway sensation will aspirate or will silently aspirate. And it also depends, we also need to take into consideration or into account the patient's swallowing biomechanics and their motor movements. So are they also having impaired swallowing biomechanics, which in the presence of upper airway sensation would place these patients at risk of silent aspiration? So it's really this entire clinical picture that's really important. I think I kind of like to see the cough reflex test as one tool or one piece of the puzzle that we have in our dysphagia toolkit, but it's not the only tool that we use to identify or quantify a patient's risk of silent aspiration. We need to take into consideration and into account the other kind of biomechanical impairments that we can also hypothesize they may present with based on what we see in their cranial nerve exam.
And is there also, I was just wondering, because you said that maybe the main thing that you're looking at is sensory. Is there also a way of assess the quality of the cough, of the response?
Yes, and that is such a good question. Yes, absolutely. We can also, I suppose, evaluate or assess the quality of the motor cough response that we hear. Historically, or probably most frequently, the way we do that is perceptually. So a clinician will listen to the cough and make a judgment based on what they hear, if it's a strong cough or a weak cough. Now, what I will say is that the literature has kind of suggested that this lacks a little bit of reliability and a little bit of validity. So I think that our perceptual evaluation of coughing still isn't perfect, but it's one thing that we can also use to evaluate the motor response. I know that some other research groups have started kind of putting on peak flow meters onto the kind of to the end of the face mask when they do cough reflex testing. And this is also giving kind of an objective measure of the motor cough response as well, which is a really cool way of quantifying cough strength. So yes, we can definitely use or assess the motor cough response as well. And I think that way of adding a peak flow meter is really innovative and really a great way to assess that clinically.
Okay, great. Before we get to how we can actually conduct a cough reflex test in clinical practice, are there any general considerations that we should make beforehand?
Yes, absolutely. I think there's probably a few things that I tend to highlight when I'm talking about cough reflex testing. And I think probably the first thing is that, if you are using a validated protocol, so I think there's about 6 validated protocols that I've put in the Spotlight article, and they're all on citric acid cough testing. But it's really important that the same methodology that's highlighted or described in the validated protocol is used, and deviations from that will interfere or affect the sensitivity and specificity of the test.
For everyone interested in screening and important related values such as sensitivity and specificity, we can highly recommend listening to episode 5 with Margaret Walsh here on Dysphagia Matters.
So I think, one thing that I realized during my PhD in looking into cough reflex testing, that research groups and researchers use very vastly different methods. So there's lots of different methods of cough reflex testing published in the literature. And actually the methods matter. So changing different aspects of the method will change the outcome of the test. And in our I suppose in our clinical practice, it can change the sensitivity or the specificity of the test in identifying risk of silent aspiration. So if you're choosing to use a validated protocol, as much as you possibly can, stick to that validated protocol as best you can. That would be my first piece of advice. I suppose secondly, kind of clinically, it's also important, to consider what you'll do with the test outcome or the test information. I think this is really important. For example, like it may be really appropriate to conduct a cough reflex test on an acute stroke patient who has lots of risk factors for aspiration pneumonia. And, depending on the result we see, we may refer them for video fluoroscopy or keep them nil by mouth temporarily, due to their known risk factors of aspiration pneumonia and silent aspiration. So in that context, it may be appropriate to do a cough reflex test. However, sometimes the results of the cough reflex test won't change the management at all of a patient. It won't change how we manage them. It won't influence how we manage them. So I think it's important to consider before we do it what we're going to do with that information and how that might change our clinical management of the patient. It's great to have the information, but it needs to contribute to our clinical picture and our clinical management. So I definitely think, considering that before we do the test can be valuable. And I think, going forward, I'd love to see the outcome of the cough reflex test inform therapy for our patients. For example, by conducting a comprehensive cough evaluation, we might be able to decide whether a patient would need, let's say, respiratory muscle strength training or cough motor training versus interventions that might target upper airway sensation. And this is kind of some of the research avenues that I'm kind of currently working on at the moment with Professor Emily Plowman in the US. So, using cough evaluation or using cough testing to inform how we conduct therapy and what types of therapy that we do for patients. So yes, I suppose watch this space, and we hope to have more research on this pretty soon.
Sounds great. There's still a lot that we can wait for. You mentioned the stroke patients that are a suitable patient group. Are there other groups that are suitable for this testing? And are there maybe also patients that should not be tested with a cough reflex test?
Yeah, such a good question. And I think, a lot of the work that I've done or how I've used this clinically has mostly been on acute stroke patients admitted to, let's say, like an acute medical assessment unit, where we're kind of screening them for their risk of silent aspiration and deciding where to go with their management from that. I think it can provide really valuable clinical information in terms of for a wide range of patient populations. I don't think it's limited to only acute stroke patients, but I think it's just also important to consider, what will you do with that information if a patient does fail the cough reflex test? What's your clinical decisions then from there? Will you place them nil by mouth? Do you have access to refer them for instrumental assessment? Is that appropriate for your patient? So I think, yes, it's definitely not limited to the acute stroke population, but it's definitely important to consider in advance how it will change their management or change our clinical decision making. And actually, to add to that as well, in terms of contraindications, we don't have good clinical guidance or good clinical protocols on this yet. So that is something to bear in mind. The research studies that have been done to date on safety suggest that it is safe, but there's certain clinical populations that I think I always kind of take into account or kind of have little red flags on, and they're often patients with asthma or severe respiratory disorders. We are giving them something to inhale, so that's often worth considering with those clinical populations as well. And the research that has been done to date has shown that the cough test doesn't promote bronchoconstriction or airway narrowing, but with those respiratory patients, I'll sometimes check in with their physician or check in with the medical team to see if they're, happy for the cough reflex test to be done, if there's any reasons why it shouldn't be done. And also, I also think with patients with head and neck cancer, sometimes if they've just had a surgery or have an open wound, especially with citric acid cough testing, it's like, a lemon acidic stimulus. So it might not be as comfortable for those types of patients as well. So taking those kind of factors into consideration as well.
Have you tried it yourself? Can you explain what it feels like?
Yes, I definitely have tried it multiple times in my research, prepping for research studies. Yes, I mean, it feels like something, if you were inhaling something really uncomfortable that hits the back of your throat and causes immediate coughing. I mean, I was inhaling the 0.6 moles of citric acid. So depending on the concentration in which you inhale, it kind of hits the back of your throat in a more or less intense way. But I absolutely could not suppress at all the inhalation, and yes, it causes an immediate cough response, eye tearing as well. So it's not the most comfortable response that it elicits.
Okay.
I remember when you were doing your research in New Zealand, and then I think I was asked as well when I did my internship there if I might join as a participant, and kept hearing everyone coughing so badly. And back then,
Yeah.
I think I knew too little about it, and I was just scared. So I don't want to scare anyone, but it was just hearing people cough all the time, and you're like, why would you do that? Why would you participate as a healthy person?
Absolutely. It blows my mind after having it done and experiencing the sensation that, we'd give this test to patient populations and they inhale the stimulus. You can see them inhaling and have absolutely no response to it. And I think that the first time that happened, that was truly fascinating. I couldn't believe, observing that this patient was able to continue to inhale this in. So yes, it's quite remarkable.
You probably had to cough yourself even though you weren't inhaling it.
Yes, absolutely.
Okay, before we head on to how to conduct a test like that, you wrote about the urge to cough in your paper. Can you quickly explain what this is?
Yes, so this is a really interesting area of kind of emerging research. There is a lot of research groups in the US looking into urge to cough. Michelle Trochet's group in New York is one of those. So this is definitely not my area of expertise, but I think it's a fascinating area of research. So the urge to cough is really looks at a scale, and there's different scales. I've put two of them in the paper, but it really looks at that when we are inhaling this sensory stimulus, or when we're inhaling a stimulus, what is the urge, or how intense is the urge that patients feel the need to cough? So patients can kind of, when they inhale a stimulus, depending on the level of, or the concentration of stimulus that they're given, they may be asked on a scale to rate their urge to cough, so how strong or how intense that need to cough was. And this is really a way of tapping into that more cortical control of the cough response. So rather than, the reflexive response, it's really tapping into that cortical control and cortical mediation of that cough response. So some patients will, even with an aspiration event, report a very low urge to cough, whereas some will report a much higher urge to cough. So it's really tapping into that cortical control of the cough response, and a really fascinating area, I think, to explore more and look into. Can we manipulate patients' urge to cough? Can we increase it? Can we decrease it? So it's kind of another area that we can tap into for therapeutic enhancement of the cough response as well.
Yes, and it's actually not always the case that we want to increase laryngeal and upper airway sensation, like you said, but for example, for patients with chronic cough, we would be aiming for decreasing it, right?
Yeah, absolutely. And I think the urge to cough can also tell us a lot about, even in that chronic cough population, can tell us a lot about what they're experiencing, what their sensory stimulus is like in their throat, and also their cortical control of that response. So absolutely, we're not always trying to enhance cough sensation in patients with blunted sensation. We definitely are. But in that chronic cough population, we're often trying to decrease sensation or decrease that cortical control of the sensory input.
Yeah, interesting. So when we want to conduct a cough reflex test, what equipment do we need? And do you know how much it approximately costs?
Yes, this is a great question, and actually something that I've looked up recently. I've recently moved to the University of Sydney, and we're setting up our kind of swallowing lab and swallowing clinic here. So this is definitely what I've been diving into recently, to purchase cough testing equipment. So the equipment that we generally need to do it is, to do the clinical method of cough reflex testing, we use a nebulizer or face mask. So often the little nebulizer is attached to the bottom of the face mask. It's like this little kind of circular thing you'll see attached to the bottom of the face mask. We also use what's called a compressor, and this is like our air supply that we use It's kind of that noisy thing that we switch on and connect the tube to the nebulizer and face mask to. We also use our citric acid, and we also use saline solution as well. So they're kind of the 4 things that's required. I think costs can vary a little bit. I recently purchased the compressor for 200 Australian dollars and the face mask and nebulizer for the same. So the equipment is not expensive. I think the main challenge, and this is the main challenge that I've been encountered, is often sourcing the tussive agent or the tussogenic agent. So the citric acid or the capsaicin can sometimes be challenging to source and sometimes requires a bit of, discussion with pharmacy if you're in a hospital department, or discussing with your clinical setting around what the policies and procedures are. Citric acid, it comes in a powder form, can be commercially available, and we add it to sterile saline to make up the solution. And the European Respiratory Society guidelines have some information around how to make the citric acid, because how we make it is extremely important. The citric acid needs to be diluted with saline, not distilled water. That's a really important point in how we make it. So yes, citric acid powder can be produced commercially. It's like $12 to buy a packet of citric acid, and we add it to sterile saline solution. But again, that can differ in terms of how and the requirements, how that needs to be made, can differ according to the setting that you are in. So a research lab versus a hospital setting. So that's sometimes the challenge that clinicians face in terms of overcoming some of that red tape that needs to be sorted before it's introduced to a hospital setting.
Okay. But once you figured that out, it's actually quite affordable, I guess.
Yes, costs are extremely low. And I think Professor Maggie Huckabee might have written in one of her research articles, I think the cost per test is something like less than $10, New Zealand dollars, that would be. So it's quite a cheap and inexpensive test to do, considering that, I think in her study, it significantly reduced rates of aspiration pneumonia when they screened acute stroke patients using the test. So I think the costs of the test definitely outweigh the benefits, definitely.
Yeah, you always have to put it into context. Great.
Absolutely.
So can we do the cough reflex test in an outpatient setting as well without having a physician in standby mode? For example, in Germany, we always need, when doing a FEES, we always need a physician somewhere nearby. So is it like this, or can we do it independently?
Yes, I love this question. I think the main problem that we have at the moment is that we really don't have good clinical guidelines for cough reflex testing for speech pathologists. So, there definitely are some risks that we need to be aware of in conducting a cough reflex test. As I said, patients with asthma or respiratory illnesses. I think in the absence of kind of clinical guidelines specifically for our profession, the European Respiratory Society have great clinical guidelines for cough testing for respiratory physicians and physiologists, and they were published back in 2007. And these tend to be my go-to in order to, when I'm conducting cough reflex testing, or kind of looking at what the best protocols and practices are. But I definitely think we need guidelines and protocols specifically for speech pathologists in doing cough reflex testing. And again, it's something that will differ according to setting. In terms of developing protocols and guidelines, this is definitely something that's been on my radar and on my to-do list for quite a while, but I haven't quite got around to kind of doing this yet. But I definitely think getting together as, clinicians and researchers who are doing cough testing internationally, I think it would be really valuable to sit down and say, okay, what is the best, or what is the optimal methods and that we can use, what equipment should we be recommending, and what type of safety policies and procedures should we be recommending to clinicians to do. So yes, I think in general the research suggests that cough reflex testing is very safe. There's no evidence that it does cause bronchoconstriction, even in patients with asthma or respiratory illnesses. So in general, the research suggests that it's quite a safe test to do. patients aren't inhaling huge volumes of citric acid. But in saying that, I think clinicians always need to have a safety protocol in doing kind of any tests we do, and a decision framework in terms of what they would do if the test goes wrong or if a patient reacts poorly to it. So I think it's always important to keep that in mind, even though we know that the safety of cough reflex testing is pretty good.
Okay. And at what time point in the clinical swallow evaluation would we perform the cough reflex test then?
Yes, so I think I tend to perform it during my kind of initial clinical swallowing evaluation when I do my cranial nerve exam. So I complete it before I conduct any oral trials, and kind of at the point where I'm, assessing the integrity of cranial nerve 10, motor and sensation. And it tends to I use the cough reflex test to often support whether I'll conduct an oral trial in an individual. So depending on whether they pass or fail, making clinical decisions around whether this patient is suitable to proceed to oral trials or whether they actually need more, an instrumental assessment based on the other presenting issues that they have from their cranial nerve exam. So that's when I tend to do it. But again, it depends on the clinical setting. It depends on the patient population. In clinical practice in New Zealand, when I worked over there, we all stroke patients admitted to this acute medical assessment unit, so kind of like A&E or the emergency department. They were all screened. The nurse conducted the cough reflex test on all acute stroke patients admitted into that area. And they would also document kind of other clinical signs like a facial droop or other observations they made, but the nursing staff did it, and then depending on the outcome of the test they would refer to speech pathology or make a clinical decision around that. There was kind of a framework set in place. So I think it depends on the setting, depends on the patient population, but that's where my two experiences have been in using the cough reflex test.
Okay, great. So you already mentioned a little bit, if the patient passes the cough reflex test, then you would go on with trials with fluids and food. Is that correct?
Yes. So again, largely depends on the goal of the test, but what typically in my clinical experience, if the patient fails the test, it kind of suggests they might have blunted upper airway sensation. So that's kind of the conclusion that we can make. I suppose the thing to consider is that if you proceed with oral trials, if the patient has failed a cough reflex test and you make the clinical decision to proceed with oral trials and the patient doesn't cough, we're kind of ended up left with this bit of a clinical dilemma, in that may be because they're absolutely fine and they have no problems, they're not aspirating, or that they're silently aspirating. So I think that, if we know that they fail the cough reflex test, we're making the kind of clinical decision that, okay, we're suggesting that this is suggestive that they have blunted upper airway sensation. Depending on your setting, your clinical judgment, if you decide to proceed with oral tests or oral trials, integrating that information into what you observe clinically is really important. And then acknowledging the limitations in terms of patient doesn't cough to oral trials. Is it because they're silently aspirating, or is it because they're completely fine? So that's important. But if a patient passes the cough reflex test and coughs, this doesn't mean that they are not going to aspirate. So just because they pass the cough reflex test, it doesn't suggest that they're absolutely not going to aspirate. It just means that if they do aspirate, we can be relatively confident that they will produce a cough response. So, that's, I think, how I use the test and integrate it into my clinical decision making, kind of understanding the limitations and what the test provides us with.
Yeah, it would be too easy just to have a pass or fail, and we know, okay, this patient is going to aspirate and this won't aspirate.
Yes, exactly. And I think, Maggie Lee Huckabee and colleagues and Anna Miles worked on developing this dysphagia in stroke protocol, where they were using this in an acute stroke population, and they had a very structured clinical protocol where a pass meant one thing and a fail meant, referral to instrumental assessment. And they were developing that clinical protocol for a specific purpose. And, it had actually very brilliant outcomes in terms of reducing rates of aspiration pneumonia. But also it's important to acknowledge that, yes, that's not always the protocol that's appropriate, depending on the population. And Maggie Huckabee would very much acknowledge that, but also that, it depends on the goals of the test, the setting in which you're in, the kind of aim of what you're trying to achieve. Are you trying to achieve reductions in rates of aspiration pneumonia, or are you trying to use this test as another clinical piece of the puzzle that we have in order to assess laryngeal and upper airway sensation? So the dysphagia in stroke protocol is great to look at if you were working in that population, but sometimes those very structured protocols are not what's needed, or not what's appropriate in different clinical settings.
Perfect. So maybe now you could walk us through the steps that we have to take when conducting a cough reflex test.
Yes, I will start by kind of highlighting that this is the clinical protocol that kind of I've grown up with, or I suppose I started my research journey with. And this was while I was in Professor Maggie Huckabee's lab in New Zealand. So, this is the clinical protocol that we used, and that was used in that research lab and used clinically in many settings in New Zealand. It's not the only cough reflex testing protocol that's out there. So, there's other validated protocols that's used. And we use citric acid cough reflex. We use citric acid opposed to capsaicin, because research suggests that acidic stimuli or citric acid more captures or more taps into the neurophysiology of this airway protective cough response that we might expect with an aspiration event. So that's why we kind of used citric acid, or leaned more towards using citric acid. So these are the steps that kind of we use in this research lab. But again, I will highlight that there's 6 different protocols publishing validated methods of cough reflex testing, and all of them should be considered, and all of them are great. So you don't have to use this specific method. But the way in which we do it is we set up our instrumentation. So we have our compressor and our nebulizer and face mask. We put saline into the little nebulizer first, and we turn on the compressor. We say to the patient, breathe in and out and cough if you need to. And they get a saline stimulus to start off with. And this kind of acclimatizes them to the test. It gets them used to inhaling through the nebulizer and just kind of getting a feel for what the test feels like. Then after that, we replaced the saline with 0.6 moles of citric acid, and that was the concentration that was validated in Anna Wallace's work through in the research lab. And then we repeat the instructions again. So with the citric acid in the nebulizer, we say breathe in and out and cough if you need to. And we observe for the patient's response. The nebulizer is on the patient for 15 seconds. So they're breathing in and out for a maximum of 15 seconds until they produce a C2 cough response. And really what we're looking for is 2 consecutive coughs in a row. So not just a single cough response, typically that 2 or more coughs in a row. And that's really just an arbitrary criteria. It was referenced in the European Respiratory Society guidelines, and they talked about this C2 cough response. So that was chosen as the cutoff value for the test. Then once the patient produces a C2 cough response, or if they don't, we stop the compressor after 15 seconds. And we repeat the citric acid trials up to a maximum of 3 times. So in order to pass the test, the patient or individual needs to produce a C2 cough response on 2 out of 3 of those trials. So that was the criteria that was developed by Anna Miles and Maggie Huckabee when they did their original validation study. So that's what I've used in my clinical practice. So it's quite simple, it's quite quick. It takes about 15 minutes to complete to do the entire test. So very simple and very easy.
You wrote in the paper that it is important to interpret the cough reflex test in the context of the patient's entire clinical presentation. What are important factors that we should consider when interpreting the cough reflex test results?
Yes, I love this question, and I think this is really important. And I think I kind of talked a little bit about this earlier, but blunted upper airway sensation alone isn't the only risk factor for silent aspiration. It's kind of just one piece of the puzzle that we have. And I think that's always, really important to consider when we're doing a cough reflex test and kind of understanding what the results mean for our patient. So it's really important to make our clinical decisions around the patient's entire clinical presentation, their medical diagnoses, their risk factors for aspiration pneumonia. Are they mobile? well, what's their oral cares like, and what's their entire cranial nerve exam like. We know that even in the presence of blunted laryngeal sensation, a patient may have absolutely fine and normal swallowing, and that they're never going to aspirate or they're never going to silently aspirate. So I think it's important that, blunted laryngeal sensation alone isn't the only thing that will increase a patient's risk of silent aspiration. So that's kind of just important to consider. And again, also considering that what we do with the outcome or the results of the test is, again, really important. Like, it might not make sense to conduct a test and keep someone nil by mouth if they fail the cough reflex test, if their other cranial nerves like 5, 7, 9, 10, and 12 are absolutely normal. It doesn't make sense to only use the cough reflex test to make or to base our clinical judgments on. So I think, again, using it in the context of our entire cranial nerve exam and interpreting it in the patient's entire presentation is really important, and also considering other risk factors for silent aspiration and aspiration pneumonia.
Okay, can we also use the cough reflex test as a follow-up measurement?
Yes, this is a great question, and again, something I'm asked quite a lot. We don't actually have very good data on using the cough reflex test as this kind of monitoring tool over time. We don't really know the kind of reliability of repeating the cough reflex test. What's the sensitivity and specificity like if we do it 3 times, if we do it 5 times? We don't really have good data on that yet for the clinical method. But again, I feel like I would say to clinicians, if you feel like repeating the test will provide really valuable and good clinical data, there's no, I suppose, obvious contraindications to repeating the test, but just considering that, the sensitivity and specificity may be different. I always think patients, or individuals, when you repeat the test, they tend to, they know it. If they have coughed previously and they have good sensation, they kind of know what it feels like, and they don't really want to inhale the citric acid, so they might do more shallow inhalations the second time you do it. So taking into consideration those factors. And also, I also think clinically, when we repeat the test, sometimes if patients after the test are made nil by mouth, or they think that's going to influence the decision based on whether they can eat or drink, sometimes they will alter. So they'll suppress their cough, or they'll elicit a cough, depending on what they think the outcome of the test will mean for them. So often taking those things into consideration as well. As we said, coughing is not reflexive. The cough response to citric acid cough reflex testing is cortically driven in some respects. So it is important to take that into account. But yes, for research purposes, we use slightly different methods of cough testing. We use kind of a method called cough threshold testing, where we tend to use multiple concentrations of citric acid and quantify what concentration the patient coughs to. So we're calling that their cough threshold. And I've done a little bit of work as part of my PhD in kind of looking at the reliability of a cough threshold method in order to use as an outcome measure for research studies. This is a slightly different method than we use clinically, in that it's not as clinically applicable. It takes a little bit longer, and it's a little bit more labor intensive. But that's the way that we quantify sensation over time for research purposes. But for clinical purposes, we don't have good data on the retest reliability of our clinical method at the moment.
Okay, you've already mentioned the evidence. What is the current state of evidence on cough reflex testing?
Yes, I mean, there's lots of studies emerging all the time. I think when we look at cough reflex testing, the key ones that I've kind of highlighted in the Spotlight article are the studies that have looked at the use of citric acid cough reflex testing as a validated tool to identify risk of silent aspiration. So I definitely think they're probably a good place to start in terms of the research as it relates to a clinical method or the clinical use of citric acid cough reflex testing. I suppose for the clinicians out there, it's also, you will come across different methods that are used by different research groups for research purposes. And again, to bear in mind that these methods differ slightly to the clinical methods. So looking at those 6 studies that have validated the use of citric acid cough reflex testing as this screening tool to identify risk of silent aspiration is probably the best place to start in terms of looking at the research evidence around cough testing.
Okay, and is there also something that you would like to have a closer look at in this field?
Yes, there are so many things. I have a document full of research questions, but I think where I would love to see cough testing go, and I kind of touched on this earlier, but I'd love as clinicians if we were able to do kind of this comprehensive cough test on our patients, and then use the results of that to inform what type of cough therapy the patient may benefit from. So if they're demonstrating impaired upper airway sensation, that we would be able to do kind of a sensory rehabilitation or a sensory treatment with them, versus if they're demonstrating impaired cough strength, that we're doing a more cough strength based training protocol. So I think kind of using more comprehensive cough assessment protocol in order to guide our therapeutic practices or therapeutic management of patients is where I'm kind of really interested in and really would love to see cough testing go. Again, a lot of my PhD work was looking at sensory rehabilitation of the upper airway. So can we actually enhance sensation in the upper airway for patients who have blunted laryngeal sensation and blunted upper airway sensation? And I think that's sometimes the really challenging thing that we see at the moment, is that we can screen patients on the cough reflex test and identify that they have impaired upper airway sensation, and they have a blunted cough response. And then from a sensory perspective, we're often left wondering what we can do to kind of improve that or rehabilitate that. So I think that's a lot of where my interest lies at the moment, in terms of how could we rehabilitate silent aspiration or blunted upper airway sensation. So that's probably the next thing I'd love to tackle.
Yeah, that's so interesting. And it's a really great point that you mentioned. We've now talked only, quote unquote, about the screening tool, but then what do we actually do with the results? So yeah, we've come to an end with our questions. Do you have any important take home or take to work message for our listeners, maybe to summarize the topic on cough reflex testing?
Yeah, I suppose to end and to summarize, I definitely think cough reflex testing can really add to our clinical dysphagia management. I've used it clinically, and it's a really great clinical tool that provides information about cranial nerve 10 sensation that we kind of otherwise don't have. I think we really don't have a better way of identifying patients with blunted laryngeal sensation, in our bedside clinical screening tool. So, and again, the research suggesting that it can really identify patients at risk of silent aspiration with reasonably good sensitivity and specificity. It's much better than our ability to identify silent aspiration without cough reflex testing. It's a challenging thing to do at bedside. And again, I think the way we integrate, or the way we choose to integrate cough reflex testing into our clinical dysphagia practice, will depend on the goals, the setting that the clinicians are working in, the patient population that they have. So these are things that definitely need consideration, and we don't have really good evidence, or a lot of evidence in a lot of patient populations, but I think it's growing, and I definitely think it adds to our clinical decision making. So yeah, I suppose I'll finish there, and that's probably a summary to finish off.
Yeah, great. Thanks a lot, Emma, for taking the time and talking about your paper and experience. For everyone who is interested in reading more about cough reflex testing, you can find Emma's clinical tutorial and further helpful literature in the show notes. If you'd like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website dysphasiamatters.org. Thanks so much for listening. Thank you, Emma, for coming, and take care, everyone.
A pleasure. Bye, guys.
Bye.
Bye.